Iowa, Nebraska, Kansas. Wow, interest from all over. That's great. Well, thank you. We're up to about 200 attendees now. So why don't we go ahead and get started? So good afternoon, everyone, and welcome to a very special edition of the Intoximeters webinar series, Rapid Drug Screening for the Roadside. I'm Phil Simmons, Director of North American Sales at Intoximeters, and I'll be your host and moderator today. Today we'll be talking about the growing nationwide problem of driving under the influence of drugs, or DUID, and smart roadside solutions that are being implemented in the field to take dangerous drivers off the road. So joining me on the panel today, I have two special guests. I have John Flanagan and Ken Stecker. So I'll go ahead and start with our first speaker who will be up, John Flanagan. So John is a recently retired lieutenant from the Vermont State Police, having served more than 27 years on the force. He was a certified standardized field sobriety test instructor and drug recognition expert. During his tenure with the Vermont State Police, Mr. Flanagan was responsible for managing the agency's traffic and recreation enforcement programs. He has also served and continues to serve as state coordinator for the Vermont Drug Evaluation and Classification Program. Mr. Flanagan also served as vice chair of the Vermont Highway Safety Alliance, interim chief of the Governor's Highway Safety Program, member of the Vermont Alcohol and Drug Abuse Advisory Council, and executive board member for Operation CARE. Mr. Flanagan currently serves as principal at Flanagan Safety Consulting, specializing in drug impairment detection and roadside drug testing. So I've seen John present on a number of occasions, and I think you'll like what he has to say. Our second speaker today will be Mr. Ken Stecker from the Michigan Traffic Safety Resource Prosecutor's Office. Ken is a graduate of Loyola Marymount University and the University of Detroit School of Law. Since March 2008, Kenneth Stecker has been the Michigan Traffic Safety Resource Prosecutor for the Prosecuting Attorneys Association of Michigan's TSRP, funded by the Michigan Office of Highway Safety Planning. Prior to working for the Prosecuting Attorneys Association of Michigan for 3 years, Ken was an assistant prosecuting attorney in Kalamazoo County. He then, for 8 years, was an assistant prosecuting attorney in Branch County. Thereafter, for 8 years, he became the Branch County Chief Assistant Prosecuting Attorney. During the 2015 Lifesavers Conference, Kenneth received the National Highway Traffic Safety Administration Public Service Award. NHTSA recognized Ken for his outstanding service in providing expert legal advice and training resources to Michigan's criminal justice community. Ken, his wife Christy, have 3 children, Marina, Sierra, and Jacob. So thank you both, John and Ken, for joining us today. So before I turn the microphone over to our first speaker, John, I think it's important to quickly refresh ourselves on the scope of the DUID problem. I have pulled a couple of key stats from a 2018 report issued by GHSA in partnership with responsibility.org that I think quickly frames the discussion. So let's start with the numbers. So I'm going to be talking just a little bit about FARS data and a NHTSA roadside study done in 2013 and 14. And I think the important thing to see is the change in trends over time. So if you look here at where my highlighter is pointing, this is FARS data for fatalities ahead known drug test result. You can see in the first bar, the light blue bar, that in 2006, the number went from 27.8% of fatalities to in 2015, 2016, near 43%. So you can see just over that 10-year period, the trend towards drivers having more drugs on board. Whereas in the same period, you could see pretty much the same level of alcohol on board fatalities between 2006 and the 2015-16 time period. But what's probably even more onerous is in that same time period, is the use of poly drugs. So these are drivers that have multiple impairing substances in their system. And just to orient you here, if you were to look at the numbers of drivers that were alcohol positive in 2006, 32.8 of them, nearly 33%, had drugs in their system as well as alcohol, compared to near 47%, 48% over the period of 2015-2016. So it's not just one single impairing drug or the other now. Now we have to worry about both of them. If you look at the 2013-14 NHTSA road survey done, you can see this in a slightly different way. So if you look at data collected on weekdays during the daytime and the weekends at nighttime, you can see that there is a much lesser percentage of folks who were determined to have alcohol in their system. On weekend nighttime at the highest, it was 8.3%, whereas for drugs, looking down here at the bottom of your screen, it was upwards of 22%. So drugs are an increasing problem on our roads, and we have to come up with mechanisms and way that we can support law enforcement by getting these dangerous drivers off the road. So I will turn the mic over to John, who will be our first presenter. But before I do, just a quick housekeeping note. We will be taking questions. Enter your questions in the control panel where it says questions. As time allows, I will pick questions at the end of the session after both speakers have gone, and I will parse them out to myself, John, and Ken as time allows. So John, I'm turning the keyboard control over to you. Can you please see if you can advance your slides?
I'm good. Thank you, Phil. Good afternoon, everyone, and thank you for joining us today. I hope you and your families are staying safe and healthy during these challenging times. For those on the front lines, thank you for your service. As some of you know, it's Police Week, and tomorrow is Peace Officers Memorial Day. Please take a moment to remember all of those who have given the ultimate sacrifice. God bless. One of the biggest threats to all highway users is still drug-impaired driving, as we know. Many states are now legalizing cannabis. This comes with increased social harms in many areas, and we still experience many other substance and poly drug use. This is why we need to leverage available technology and tools to better carry out our mission. I believe roadside oral fluid testing needs to be one such strategy. In fact, many states across the country include roadside testing as a strategy in their respective strategic highway safety plans. I was one of those skeptics at first about this technology until we used it in a pilot project and proof of concept several years ago and found it highly accurate and reliable when compared to confirmation blood and oral fluid tests. Let's look at the growing problem a bit more in fatally injured drivers. Looking at this slide, that's almost half and up 50% from the last decade. That's alarming. These are not acceptable losses, and we should and can do better. Some of the latest FARS data from 2017 and 2018 show alcohol-related fatalities decreased 3% in each of those years. So we're not moving the needle in the right direction in drug-impaired driving deaths. We have made significant progress in alcohol-impaired driving, and roadside alcohol testing certainly has been a key strategy to that, along with legislation and enhanced law enforcement training steps in the past few decades. So Ask yourself this: why are we not broadly using roadside testing in the US yet, when it's available, it's accurate, and it's reliable? We need to think deeply about that. Every law enforcement agency that does traffic enforcement should have this tool in their toolbox. Several jurisdictions have used or are using SoToxa with encouraging results. In Michigan is one such state, which you'll hear from Ken Stecker shortly, really has been the US leader in this area and is on their second pilot phase with legislative approval. Canada also has approved SoToxa for use of roadside oral fluid testing, and several countries are now using it too. These include Spain, Italy, Germany, and Vietnam, just to name a few. I should also mention that SoToxa was formerly the Alere DDS2 and was rebranded last year by Abbott. Although we've seen a high correlation in accuracy, we've had a few errors that can be due to contamination of samples. You can get an invalid sample, for instance, if not enough oral fluid is collected in the collection swab, which requires 1 milliliter, which will turn blue when the user has enough collected. It's just as important to establish that any possible impairment at roadside may be substance-driven as it is to even rule out an early medical condition that may be causing the observed impairment. So think of a case also where a driver has caused serious injury or death to another, and they may be injured themselves. We may have the inability to screen or even make some limited observations, but have some suspicions that this is substance-driven. A roadside test may be probable cause to continue obtaining an evidentiary test and continue our investigation, because the window is short-lived to obtain an evidentiary test later. That's crucial evidence we don't want to lose. While some states have an any amount standard for illicit drugs, not that many cases are brought without some articulable facts and circumstances of impairment. But just one more tool that they can use. We also can't overstate the potential impact on deterring drug-impaired drivers from getting behind the wheel in the first place. If they know that law enforcement has the ability to drug test at roadside, let's think about how well it has worked for alcohol in the last couple of decades. There really are 3 key benefits to SoToxa. It's highly mobile, it's easy to use, and you get rapid results within 5 minutes. It's also less invasive, much more likened to breath test than blood or urine collection. The current cartridge panel detects 6 drug classes: amphetamine, methamphetamine, THC, opioids, cocaine, and benzodiazepines. The cutoff levels are set to detect recent drug ingestion. You can print those results roadside, has a memory, and data that can be downloaded. There are some cases where a subject may not be able to provide a sample due to dry mouth or potentially a mouth injury. While any officer can train or be trained to collect a sample, local policies may dictate whether the officer needs to be a DRE or has been ARIDE trained or other advanced impaired driving detection trained. If possible, screening should be used in all impaired driving cases. Even with suspected alcohol, we know the high prevalence of alcohol combined with other substances. Whether it's a DUI court model or post-adjudication, it is important to effectively treat all substances and not have that individual in a position to reoffend. We also know that people always aren't completely honest at roadside. Some can be persuasive to convince that officer that they have a certain medical condition or that they're just really tired, but it's really substance driven. So instead of potentially letting a drug impaired driver go and potentially do harm down the road, a roadside drug test may just tip the scale and require further detention and perhaps get to a DRE for a drug influence evaluation. This isn't meant to replace that process. This should only increase those evaluations for DREs. It's also important to remember that the arrest decision should be based on facts and circumstances of impairment and not a positive drug test alone. For example, some could test positive for a benzodiazepine that is prescribed and may not be impaired. So I believe we've checked the boxes on much of the feedback and concerns that I've collected over the past few years. We know it's reliable. However, it's a presumptive test and there are certain limitations. They're not perfect. There can be a few false positives and negatives. That's why impairment is key. And it does not test for every substance under the sun. All tests should also be confirmed whenever possible. SoToxa is the most portable and mobile analyzer on the market. It can even be carried easily on a motor. Others are the size of a toaster or larger and are not portable for the mobile environment that law enforcement works in every day. There certainly is a cost with any tool. You can compare this like purchasing a portable radio. Legislation may be required in your jurisdiction if not already permissible. There are highway safety grants that fund equipment, possibly through your state highway safety office or other options. So the Kern County decision out of California found that the roadside oral fluid testing using lateral flow immunoassay admitted those results, finding that they were scientifically reliable. Although this is one case in California, it does set some jurisdictional precedents. I also know that Ken is going to discuss this in more detail shortly. So there should be strong consideration for roadside testing to be included in your strategies in various highway safety plans. Because we can't yet find a way to sample brain tissue yet. This is one of the best tools that we have out there that's available to make our roads safer. In closing, thank you again for this opportunity, and please take care of each other. I will now turn it back over to Phil Simmons. Thank you.
John, thank you very much for that presentation and sharing your firsthand knowledge of keeping the roads safe. It's very much appreciated. Again, we will save the questions for John till the very end of the webinar. So if you could kindly enter your questions into the control panel. With time allowed, we'll address them all at the end. Before I turn the mic over to Ken, we have a couple of polls, interactive polls that we want to gather some data on. It's always important when we are developing new tests and assays that we understand the prevalent drugs to be tested against. So you should see on your screen a polling question that says, currently the SoToxa test panel includes amphetamines, benzodiazepines, cocaine, methamphetamine, morphine, and THC. What we are interested in knowing is which of the following drugs would you like to see added to the panel in future releases? Please select your top 3. I'll go ahead and give a minute for anybody to register their polling answers, and then we'll move on to poll number 2. So thank you. Looks like a lot of you are answering the poll. That's very much appreciated. It's always kind of a nice break to have an interactive poll like this. It's amazing what technology can do these days. All right, we're still collecting a few responses, so let's give it some time, and then we'll move on. Thank you again for your feedback. All right, this question will close in 5 seconds. All right, close enough. Thank you for your answers on that poll. We'll now move to the second one. Do you see prevalence in your community and have a need to test for SOMA? And I'll show my mispronunciation here and say carisoprodol. So if you could please spend a minute answering this poll question. At the end of the presentations, if there's time, I'll share the poll results. So about half of you have voted. Thank you very much for that. All right, the poll will close in 10 seconds. So please take the last few seconds to register your vote, and then we'll move on to Ken. All right, thank you for that. Again, we'll share the poll results at the end of the session today. So I'm going to turn the mic over to Ken Stecker. Ken is going to have a very, what I imagine will be a well-received presentation on the Michigan pilot study. So Ken will obviously go into much more detail, but as of right now, Michigan is holding the largest roadside oral fluid pilot project in the nation. So Ken, floor is yours. Can you move your slides?
I don't seem to be able to move my slides.
All right. Try now. You're moving them.
I am. Let's see if I can move them back. I'm trying to move them back. Huh.
Here, I'll get you back to the beginning, Ken.
Okay, I may just say next slide to you.
Well, there you go.
Let me try again.
You got it. If you just want to start there.
Yes. Thank you, Phil. And thank you, John. And thank you, Jennifer, for everything you've done. And thank you, attendees, for listening in to this very important presentation. I'm going to cover the topic of Michigan's oral fluid roadside testing. Preliminary oral fluid drug screening on the roadside has many benefits. Utilizing oral fluid for preliminary drug screening has the potential to expedite the drug-impaired driving investigation process. Since oral fluid has a short detection window, it makes an ideal specimen to collect. Oral fluid is collected very close to the time the driver was operating the vehicle, lending additional credibility to the test results, and drivers may be more inclined to consent to a non-invasive oral fluid swab versus a blood draw. Michigan is the first and so far only state in the country to enact a law that put in place a statewide oral fluid roadside analysis pilot program. This effort has been recognized nationally. As of October 1st, 2019, Michigan is now into phase 2 of its pilot program. Phase 1 ran for 1 year, November of 2017 to November of 2018 in 5 counties and resulted in 92 oral fluid samples.
Phase 2 has been expanded to over 50 counties in Michigan and includes all drug recognition experts throughout the state. This is obviously what we're facing today is without a doubt marijuana, as mentioned by John, both medical and recreational. In Michigan, we are both a medical and recreational marijuana state. Hence the reason why this particular instrument is so much more important at the roadside. As mentioned earlier by Phil with statistics, the National Highway Traffic Safety Administration roadside survey that was conducted in 2014, and then obviously the final report was submitted on February 6, 2015, show that alcohol use has declined dramatically. They did 2 roadside surveys, one in 2007 and one in 2014. So they had to compare those surveys. And when they compared the survey, as mentioned, alcohol use has declined dramatically. Only 1.5% of weekend nighttime drivers had BACs at or above 0.08%. However, this is what caught everybody's attention, including NHTSA. 22.5% tested positive for drugs, an increase from 16.3% in 2007. And this definitely caught everybody's attention. 12.6% were positive for marijuana compared to 8.6% in 2007. That's a 50% increase from 2007 to 2014. Michigan drug-related crashes, certainly like other states, has gone up. 2010, we had 133 drug-related crashes. In 2018, we had 603 drug-related crashes. This is just an example of what we're seeing out there. This obviously caught everybody's attention. It made nationwide attention. We had an individual by the name of Mr. Pickett, the defendant. There's a picture of him driving down the road. He killed 5 individuals on their bicycles and also seriously injured 4 others. You'll notice he had no alcohol in his blood. But what he did have in his blood, and it came back from the Michigan State Police Laboratory, was amphetamine, a stimulant, methamphetamine, a stimulant, hydrocodone, an opiate, and tramadol, a muscle relaxant drug. And that was certainly absolutely incredible. And then 4 other drugs also were detected but not quantified. And certainly he was found guilty of all 5 counts of second-degree murder and 4 counts of driving while intoxicated causing serious injury, and he's now in prison for 25 years to life. Swift family tragedy. Just to give you some background as to how this law took effect in Michigan, I really believe it's important to give you some background. On March 20th, 2013, a traffic crash at the intersection of US 2 and South Hill Road in Gladstone, Michigan, took the lives of Thomas and Barbara Swift of Escanaba, Michigan. The couple died of injuries sustained when the vehicle was struck by a semi-trailer truck that disregarded the red light at the intersection and collided with their vehicle. The driver of the at-fault semi-trailer truck was charged with 6 felonies in connection to the fatal crash. 2 counts of operating while intoxicated, presence of a controlled substance causing death, 2 counts of reckless driving causing death, and 2 counts of driving while license suspended causing death. Following a trial, the jury found the driver guilty on all 6 counts, and he was sentenced to a minimum of 5.5 years in prison. Following the loss of his parents, Brian Swift contacted Senator Thomas Casperson, who introduced Senate Bill 207 and Senate Bill 434 to combat drug-impaired driving by implementing an oral fluid roadside analysis pilot program. Both bills passed and were signed into law by Governor Rick Snyder, Public Act 242 and 243 of 2016, known as the Barbara J. and Thomas J. Swift Law, and it became effective on September 22nd, 2016. So the Barbara J. and Thomas Swift Law works as follows. As mentioned, Public Act 242 and 243 came into play. The law authorizes the Michigan Department of State Police to establish a one-year pilot program in 5 counties for roadside drug testing. It also requires the Michigan State Police to develop a written policy for the implementation of the pilot program and the administration of roadside drug testing. It also put into place that the Michigan State Police has to adopt rules to implement the pilot program, which they did. And next, it required the Michigan State Police to report the pilot program to certain committees of the legislature within 90 days after the pilot program concluded, which it did. It also finally allows the Michigan State Police, subject to appropriation, to establish pilot programs in other counties for up to 1 year, which it did. That's the second phase, as I mentioned earlier. The Barber and Thomas J. Swift law did more, though. And here's what I need you to understand and really see where Michigan came from when it passed this law. So Public Act 242 of 2016 states that a peace officer who is certified as a drug recognition expert officer may administer a roadside oral fluid test if they have reason to believe a driver is operating a vehicle under the influence of a controlled substance, and the drug recognition expert may arrest a person in whole or in part upon the results of a preliminary oral fluid analysis. A person who refuses to submit to a preliminary oral fluid analysis upon a lawful request by a peace officer is responsible for a civil infraction. Public Act 243 of 2016 authorized the Michigan State Police to establish a pilot program in 5 counties in Michigan for roadside oral fluid testing to determine whether an individual is operating a vehicle while under the influence of a controlled substance. The law states that a preliminary oral fluid test will be performed by a certified drug recognition expert officer. They took a methodical, slow, and efficient approach when they put this into play. A certified drug recognition officer means a law enforcement officer trained to recognize impairment in a driver under the influence of a controlled substance rather than or in addition to alcohol. The committee was formed. The oral fluid roadside analysis pilot program committee researched the capabilities of several models of oral fluid test instruments by the manufacturers. Part of the committee, and if you do this in your state, you want committees and members as follows. You want your traffic safety resource prosecutors involved in this committee, the traffic service section, the alcohol enforcement unit, the impaired driving unit, the drug recognition expert coordinator from the Office of the Highway Safety Planning in your state, the forensic science division at your laboratory, and the executive resource section of the state police agency, in essence, the attorneys. The counties selected for the oral fluid roadside analysis pilot program were chosen based on the number of serious injury and fatal crashes involving impaired driving, trained drug recognition experts and drug recognition expert prosecutors in the county, as Michigan has drug recognition expert prosecutors, their knowledge of the program and willingness to participate in the pilot program, and to reflect Michigan's highly varied population density. 5 counties were selected: Berrien County, Delta County, Kent County, St. Clair County, and Washtenaw County. We had a populated counties with Kent County, that's Grand Rapids, and Washtenaw County with Ann Arbor, and not as populated dense with the county up in the northern part in the Upper Peninsula. That would be Delta County and also St. Clair County to the far east in Michigan. The drug recognition experts were all part of this. All law enforcement agencies were represented in this pilot program, which was outstanding. 12 participating law enforcement agencies were involved initially because they wanted to go about this methodically, slowly, and efficiently and get it right. Only the 27 drug recognition officers within those 5 counties were initially participating in the oral fluid roadside analysis program. All law enforcement agencies in the selected counties agreed to participate in the pilot program. The selection criteria was very intense, to say the least. Each instrument was evaluated with a goal of selecting an instrument that included a number of criteria. Portable handheld instrument for ease of use in the field, rechargeable and fully automated analyzer, on-screen instructions, results within 5 minutes or less, the cutoff level no higher than 25 nanograms of oral fluid, battery life capable of running up to 50 tests, capacity to retain at least 1,000 test records, and most importantly, positive, negative, quality controlled cartridges included with the instrument. The oral fluid test instrument that was eventually, what happened is manufacturers were given an opportunity to give a presentation and demonstration to committee members. And also 7 different oral fluid testing manufacturers gave presentations and were evaluated by the committee members. This was once again very intense and very competitive in terms of making sure we got the right instrument for our state. The committee members developed specifications that met the needs of the pilot program. The selection of the instrument, as mentioned earlier, once again, another thing that's really key is the last bullet here. Minimum test panel to include amphetamines, methamphetamines, the opiates, the cocaine, the benzos, and the cannabinoids. That was really key in terms of selecting the right instrument here. So the selected instrument that we chose was initially the Alair DDS2 roadside oral fluid instrument as the screening instrument, which gives a positive or negative test result rather than a specific nanogram level. The Alair DDS2 also had specified threshold cutoff levels, which are set by the manufacturer for each tested drug class, now known as the SoToxa Mobile Test System Abbott Laboratory. This instrument is fantastic and it has worked efficiently and correctly in our state. The SoToxa Mobile Analyzer, there's a picture of it more succinctly. Once again, an exceptional instrument, and it took a lot of research and a lot to make sure we got the right instrument here. We wanted to make sure we got it right from the get-go. The quality control, this is one of the really good features of the SoToxa. The quality control testing to validate the SoToxa is correctly detecting positive and negative results each day prior to use. And also, once again, and John mentioned this, and certainly John has a lot of experience and much more experience with the hands-on in terms of using this instrument, and he touched on this. Rapid sample collection, sample volume adequacy indicator, and robustly designed for active swabbing, which is certainly one of the key aspects we want to make sure this device does. Test instrument, once again, I want to emphasize to you that it's compact and portable, easy to use, results within 5 minutes. This is the one that I really get a lot of good feedback from the officers. Easy to read positive or negative results, and it can store up to 10,000 tests and comes with a printer. The SoToxa drug panel, you'll see the cutoffs right there, and you see the 6 drug panels, the amphetamines at 50, the benzos at 20, the cannabis at 25, and the cocaine at 30, the methamphetamine at 50, and the opiates at 40. The oral fluid concentration thresholds may look different than the blood concentration thresholds you are used to seeing. Don't confuse the two. They're not equal. For example, studies have shown that 1 nanogram of THC in the blood is equivalent to approximately 30 to 40 nanograms of THC in saliva. The roadside use, this is how it works at the roadside. The test instrument will display a positive, negative, or invalid test reading for each drug category. Positive result indicates presence of the drug in the driver's system. It does not detect impairment, as John pointed out. It's just one tool in the toolbox. I love how he said that. Negative results, below the cutoff level. Negative results does not preclude a driver from being impaired. That's why initially, wanting to make sure this was done right, we had only drug recognition expert officers, and we still only have drug recognition officers using this because it could be below the cutoff level, but nonetheless, because of the drug recognition experts' training, experience, and education, they still may see a driver that's impaired. Invalid results means it's normally insufficient volume of oral fluid. The SoToxa screen looks like this. You can see clearly cocaine is positive, opiate positive, methamphetamine negative, THC negative, the benzos and the amphetamines negative. This is so easy to read. It's very clear on the screen, including the time and the date above. Validation test, a separate, what we did in Michigan is we had a separate secondary oral fluid test that was completed when possible from a suspect. And a number of them did volunteer for the second oral fluid test. It's completely voluntary, and it's sent to the Forensics Fluids Laboratory in Kalamazoo for analysis. And it's certainly returned within 24 hours. And this is what the secondary oral fluid test looks like in terms of collecting it. And as I previously mentioned, we had a number of individuals on the roadside that took the second voluntary test. Blood analysis is collected also when an arrest is made, either voluntary or by search warrant, because once again, this particular sample, the oral fluid sample, cannot be used in Michigan for evidentiary purposes. It's used for probable cause purposes. It's another tool in the toolbox, along with the other factors, the standardized field sobriety test, the physical and mental condition of the defendant, and also the driving and any admissions and or state confession or statements of admissions made by the defendant. Program process. Participating DREs shall fully develop probable cause factors. I can't emphasize that enough, that you don't solely rely on the results from this test, but it's a great, great thing to use, especially to put in your search warrant affidavit. Best practice, this is really important. We have two key best practices in Michigan. The drug recognition officer does not view the SoToxa results until the DRE has completed their investigation or evaluation, and the drug recognition officer uses the SoToxa results in the affidavit for a blood search warrant. I can't stress enough that the judges love to see this in the search warrant affidavit. They have really, really endeared themselves to this with respect to what is put in the search warrant affidavit. This is what their advice of chemical test rates form now looks like. It had to be modified to cover this particular instrument, and you can see that in the yellow highlighted. It talks about took a preliminary breath test or oral fluid test before your arrest. You must still take the test I'm offering you. So that was put in the advice of chemical test rates. We made sure we filled that hole. Phase 1 information, as mentioned when I started off, the counties that participated are those 5. We had 31 drug recognition experts participate, 92 oral fluid roadside tests conducted with 1 refusal. 89 drivers were arrested during the first pilot, 79 drivers consented to a blood draw, and 8 search warrants were obtained. The results are right here, and the results are also in one of your handouts, and that handout is the February 2019 Michigan State Police Oral Fluid Roadside Analysis Pilot Program Report. I can't stress enough, if you want this particular program to come to your state, you need to read that report that was put out by the Michigan State Police. It's very detailed and thorough. you can see that most of the tests out of those 92 tests tested positive for THC. That should come as no surprise in a state like ours that's both a medical and recreational marijuana state. Phase 2 information, this is the most up-to-date information I have as of earlier this week. It began on October 1st, 2019, and will conclude on September 30th, 2020. Nearly every county has a DRE available to assist with the oral fluid testing, and now we have approximately 125 drug recognition experts that are currently participating. These are the counties now covered. Now in phase 2, additionally, there have been over 300 tests completed within the first quarter of the phase 2. Significant difference between phase 1 and phase 2. DREs are assisting other officers by utilizing the roadside oral fluid instrument. That's why you see the increase in the number up to over now or near over 300 tests. This is a case I get a lot of questions about intrusiveness, and I get a lot of questions about Fourth Amendment issues. Keep in mind Birchfield versus North Dakota from the United States Supreme Court. And here's one of the parts of that opinion that I found to be very, very helpful with respect to oral roadside analysis if this issue comes up from somebody that has concerns. The United States Supreme Court stated the physical intrusion is almost negligible. The tests do not require piercing the skin and entail a minimum of inconvenience. Requiring an arrestee to insert the machine's mouthpiece into his or her mouth and to exhale deep lung air is no more intrusive, and this is the key, than collecting a DNA sample by rubbing a swab on the inside of a person's cheek. And they cite to Maryland versus King, a United States Supreme Court decision in 2013. Lastly, as John mentioned, there is one case out there, and it's from the Kern County Superior Court in the state of California that had to decide whether this instrument is admissible for evidentiary purposes. And even though California does not have a law like Michigan does, the court decided as follows. They said this: the court finds that the correct scientific procedures were used in this case. The court further found that there's sufficient reliable evidence of the drug screening test administered on October 13, 2013. I have those transcripts. I have the court order. Now keep in mind, California is a FRYE state, F-R-Y-E, meaning for purposes of scientific reliability of some sort of instrument, or if you want to get something else in from an expert. In Michigan, we are a Daubert state, D-A-U-B-E-R-T. I actually believe the FRYE threshold is more difficult than the Daubert threshold. So hopefully in Michigan, in the upcoming years, we have a Daubert hearing, so we introduce this instrument into evidence for and show that its scientific reliability, which I believe we would have no problem doing, and therefore use it for evidential purposes at the actual jury trial or bench trial. And I believe that is, this is Michigan and how we have it where we can introduce. And then certainly you see some pictures of how the publicity we received as a result of expanding the program and when we initially started out. You'll see in the bottom left-hand corner, that is actually the report, the name of the report, the Oral Fluid Roadside Analysis Pilot Program report. And in conclusion, on November 8, 2017, the Oral Fluid Roadside Analysis Pilot Program officially began. With the ever-increasing impaired drivers and fatalities, the opiate epidemic, and states legalizing marijuana, it's a great time to implement this program in your state. The Michigan State Police and members of the committee are very proud of the accomplishments so far with the Oral Fluid Pilot Program, and we look forward to assisting you if, in fact, you need assistance with putting this program in place in your state. And I'll leave you with this. And I believe that may be my last slide.
All right, Ken. Well, thank you for that. Oh, you have a quote. I'm sorry.
Yeah, absolutely. And I knew that quote was coming, but I didn't know if the slide was going to move. And this is from Brian Swift, the one that really was the leader getting this in place in Michigan. Sadly, because of the death of his parents, we have worked hard over the past year to turn the horror of losing our mom and dad into saving others. Our pain never goes away, but we know my parents would want to help others, and we think it is worth the fight. And there's my contact information if in fact you want to reach out to me if you have any further questions. Thank you, Phil. I really appreciate the opportunity, and it truly was an honor to present here today.
Well, thank you, Ken. We can tell you're passionate about the cause, and we thank the state of Michigan for kind of leading the way for a lot of us on this. So it's very important work that you and your team have been doing. So we have about 10 more minutes left in our webinar today. So I thought first, before we got to the questions, we can share the results of the poll that we ran earlier. So the first poll question, and hopefully you can see this on your screen. The first poll question was which additional panels to include on the SoToxa. And I think this is important because it can give you an idea of what your colleagues nationwide are seeing. Maybe not a surprise, but the top 3 drugs that were suggested to be added to a panel were fentanyl, oxycodone, and it looks like tramadol coming in third. So thank you for that. Thank you for your responses. That'll be very valuable feedback that we can give back to the scientific teams that develop the assays. So the result of the second poll question should be up here on your screen more momentarily. Do you see prevalence in your community and have a need to test for soma? And about, I think there were 75% of you answered the poll question, so very high answer rate. And 29% of you said yes, and 70 said no. So that can give a good indication of really what we're seeing kind of in the field. So why don't I now spend a few minutes getting into questions? John and Ken, we're gonna unmute you. I will read some submitted questions. Unfortunately, we're not gonna be able to get to them all. We have a lot of questions. What I will point you to is if we do not answer your question here on the webinar, I will direct you to the resources that we provide that you should see in your control panel. You should see some information, the oral fluid summary report based on the Michigan pilot study, as well as some product specific information about the SoToxa. In addition, if you don't hear your answer to your question addressed here live on the webinar, we will be following up. These questions are captured, and we will be following up with an Intoximeter's representative to answer your question. So give me a second. Let me scroll through the questions and either answer myself or parse them out to Ken or John. So one of the first questions we got, and I think Ken addressed this in his presentation, but it was to the cutoff levels and specificity of the SoToxa product. So I won't get into the cutoff levels of all 6 of the drug panels, but I will get into the cutoff level for marijuana, since that seems to, or THC, since that one seems to be the utmost important these days. So the cutoff level for THC is 25 nanograms per milliliter, but I will caution you that that number is sometimes misinterpreted. So that number of 25 is the cutoff level for THC in oral fluid, and as Ken mentioned, there's roughly a conversion factor. So 20 nanograms of 40 nanograms of THC in oral fluid equals about 1 nanogram in blood. So, you know, be careful not to conflate the 2 different mediums. The next question, I will go ahead and I will parse out to Ken. Ken, I believe you're unmuted, so the question is, your crime labs do oral fluid drug confirmations. Maybe can you readdress how confirmations are done in your pilot study?
Right. The Michigan State Police does do the confirmation, and also that second test is confirmed. So in essence, we have 3 different tests, and it's set up where the Michigan State Police is certainly involved in this, and they, without a doubt, confirm what was done previously.
Okay, great. Thanks, Ken. John, one for you. So this one has to do, it's a common question that has to do with what I would interpret as per se limits for THC. So the question is there a measure like for alcohol that is deemed over the limit or that is incapacitating for marijuana?
Yeah, Phil, that is a common one. And I would just say that the science broadly doesn't support a particular per se level for THC, even though that states have gone ahead legislatively and set limits. They've pulled those out of someplace, but it's certainly not science-based. We know that certainly people, impairment can happen with THC under 5 nanograms, and we can have someone who has a level over 5 nanograms that may not be impaired.
If I can follow up on that.
Thank you. Yeah, sure.
There are 6 states, as John mentioned. 3 have a 5 nanogram threshold. 1, there's a presumption in Colorado. 2 states have a 2 nanogram THC threshold, Nevada and Ohio, and then Pennsylvania has a 1 nanogram threshold. There's, as mentioned by John, and he's absolutely correct, there's no correlation there, and that's why it's really frowned upon. And our state decided not to take that position in terms of putting a number in place and relying on the officers to detect the impairment through their investigation.
Thank you, John and Ken. So let me get to a couple other questions. So the next question is there training on how to read the SoToxa device? So the answer is unequivocally yes. There are multiple ways that training's provided. So upon testing or purchase of a SoToxa device, you can be trained in person. And we also have a pretty interactive video training from Abbott, the manufacturer of the SoToxa device. But I think you'll see if you were to do a demo, it's pretty intuitive. You have a simple collection process, a 5-minute wait in order to get results. And for a panel of 6 drugs, you simply see a positive or negative result according to prescribed cutoff. All right, let me, I'll tell you what, let me get one more. Sorry, I'm trying to scroll through here. How often do calibration verification checks need to be performed with the SoToxa? And what we have decided in collaboration with the manufacturer Abbott is that a series of yearly recertifications, or sorry, annual certifications are recommended in order to keep the SoToxa in optimal operating condition. And that includes calibration checks. But as far as day-to-day operation of the system, that is purely done using, I believe Ken showed the positive and negative control cartridges that are basically used to align the camera in the system to make sure everything's diagnosed and working properly before a subject test. Ken or John, anything you want to follow up with there?
I think you nailed it,
Not
Phil.
on that. I do want you nailed it, Phil. I just want to mention as to the training, you guys do an exceptional job with the training, without a doubt, through Fred Delfino. And I will tell you this, when we went to phase 2, we had 6 different trainings in 6 different regions to really go over the instrument with the DREs that were now going to be part of using this particular instrument on the roadside. Exceptional training.
Thank you, Ken. Much appreciated praise. So that ends our time here today. I want to thank John and Ken again. Very valuable firsthand information. It's always better to kind of hear information like this from colleagues across the nation, as we all see different things within each one of our states, and it's always helpful to network. Thank you to everybody that attended here today. It's great that you can all spend an hour of your time with us and learn more about a growing problem. But the good news is there are people out there who are working every day to help support officers out there on the front line. So thank you to everybody again. Be well and stay safe. Bye-bye.